Today I'm going to show you how to anesthetize a patient for NG tube placement and 2 ways to curl the NG tube so that it's more likely to go straight around the nasopharynx and right down into the esophagus where it belongs.
Background.
Patients consistently rate NG tube placement as the most painful thing we do to them in the ER. And that's because it really hurts to have a hard plastic tube shoved into your nose. Things get especially uncomfortable and difficult once you reach the back of the nasopharynx and the NG tube has to make this 90-degree turn to drop down into the esophagus. This is where people gag, they spit, they cry, they curse, you sweat, and it sucks for everyone.
Anesthesia.
The first and most important step is to anesthetize the patient. One good way to do this is with viscous lidocaine. I like to take a 3 cc syringe and I squirt 3 cc's up each nostril and I have the patient snort it back and swallow it. And then I even squirt a little bit in the patient's mouth. After that, I take 2 tongue depressors, tape the ends together on one side, and put them on the patient's nose to hold in the viscous lidocaine. After about 15 minutes, the patient should be nice and numb and ready for the tube.
Making the turn.
Most of the time, good anesthesia and going slowly when advancing the NG tube will help you make terror turn with no problem. But sometimes you have to make that NG tube curve a little bit to make the turn. Here are 2 ways to do it. So the first way to do this is to take a rapidly dissolving suture type, such as plain gut or chromic, and run it through the most distal port on the NG tube. Now I am using nylon here because it shows up better on the camera, but make sure you use a rapidly dissolving suture type. Remove the needle, that's important, and you'll notice that when you put a little gentle traction on the suture as you're holding both ends of it, it curves the tube down. So when you are advancing the tube into your patient's nose, once you meet a little bit of resistance in the posterior nasopharynx, put a little gentle traction on both strands of the suture, and it'll tip that tube inferiorly just enough for it to make that turn. Once you feel it advancing easily, release one strand of the suture and pull on the other strand to completely remove it. That's why we use absorbable suture, because if you mess it up and the patient ends up eating the suture, well, it'll be broken down in a few days and shouldn't cause any problems. This technique does take a little practice, but it can really work in tough cases. The other way to curve the tube is to take one of those white oral airways with the groove in the side and press the NG tube into that groove. Then you dunk the entire thing into an ice bath. And after a couple of minutes, as soon as you remove the tube, it's got this amazing curve to it. Now that curve won't last long, so as soon as you remove it, start placing it in the patient. It's a little cold and uncomfortable, but it works. Once you've secured the tube, you need to verify placement, and here's one wonderful way to do this. Yeah, it tasted the same, just with a little extra essence of vomit.
Yay!